My name is Eden Elmasude, and I'm here with my colleague Justin Iancola.
We're psychiatry residents. We put this material together in collaboration with our faculty advisor, Dr. Matos, and Dr. Cooney. We're talking about delirium because it is a common but difficult issue to deal with in the hospital. We hope after this presentation you will feel more confident evaluating and managing delirium appropriately.
We'll start with a case and then follow this roadmap to address diagnosis, treatment, and assessment and plan. It's 3 o'clock and you're on night float. You get a text from the nurse saying that the patient, Ms. Green, is getting out of bed, combative, and is a fall risk. Before getting out of bed yourself, you check your sign-out sheets. This is a 65-year-old woman with a history of hypertension and diabetes, presenting with altered mental status, which remains of unknown etiology. The day team notes document that she was able to have a coherent conversation earlier in the day. How do you know if this is delirium?
First, delirium is a syndrome, a constellation of symptoms that present similarly regardless of the underlying etiology, kind of like fever. It is a manifestation of an underlying process. Fundamentally, delirium is a disturbance in attention and awareness. This is an acute onset change from baseline and is associated with other cognitive changes. Core symptoms include impaired attention, people seem distractible, impaired memory, impaired language, motor abnormalities, disorientation, and changes in thought process. Less common are visual and other sensory hallucinations, or affective lability, which means a change in emotional state or appearance within minutes, unrelated to context.
So remember, delirium is a disturbance in attention and awareness that develops over hours to days. It is a change from baseline, and it fluctuates in severity. This is important because there's a very high incidence of delirium in the hospital, especially in the ICU, with up to 87% of patients experiencing this. And it's very distressing for patients, families, and hospital staff. It leads to longer hospital stays, more complications, accelerated cognitive decline, and it's an independent predictor of death. So essentially, there's high morbidity and mortality.
Delirium phenotypes can be classified as hyperactive, hypoactive, or mixed. Essentially, delirium looks different depending on the patient and the underlying cause. These are differentiated by what you might imagine: increased activity and restlessness for hyperactive delirium, and for hypoactive delirium, decreased activity or listlessness. There are also non-motor symptoms. In hyperactive delirium, there can be more speech. This is also louder and faster. Be aggression, combativeness. They can be in a hyper-alert state or have hallucinations. In contrast, in hypoactive delirium, there is less speech, decreased alertness, and hypersomnolence. And of course, there can be a mix of these two types. Knowing this, how do you actually assess the patient?
The differential here is actually fairly short, because we first need to decide whether or not we are dealing with delirium. If so, the real differential is to find out what is the underlying cause. You have to distinguish delirium from dementia, sundowning, which is essentially neuropsychiatric symptoms of dementia, non-convulsive status epilepticus, a focal neurological disorder like stroke, a primary psychiatric disorder, or of course, delirium. The first steps are to check vitals and recent labs, then assess history, typically from notes and talking with nursing about the course of symptoms. And then a bedside mental status exam. You can ask them to say the days of the week backwards to evaluate attention and concentration, or to spell world backwards. Remember, most of the workup you have to do is figuring out the underlying cause of delirium so that you can treat that. Now, the big thing is figuring out what history, exam, labs, or imaging you need to find the underlying cause or causes. It can be due to a general medical condition like hypoxia, hypo or hyperthermia, infection, or metabolic disturbances like electrolyte imbalances, acid-base disorders, hypoglycemia, hepatic or renal failure, a vitamin deficiency, or endocrine dysregulation. Next, substance intoxication. Straight drugs, in particular synthetics like K2 and PCP, anticholinergics, opiates, benzodiazepines, histamine blockers, steroids, centrally active antihypertensive, and Parkinson's medications. Also substance withdrawal, in particular alcohol, opiates, or other sedatives. There can also be multiple etiologies, like post-op delirium, sleep deprivation, fecal impaction or urinary retention, or simply being in an unfamiliar environment like the hospital.
Some patients are more susceptible to delirium than others, so it is helpful to consider the patient's risk factors. Basically, these are baseline impairments of cognitive reserve that make the patient more vulnerable to developing delirium. Dementia is a huge one, and the risk is correlated with the severity of dementia. Other risk factors include advanced age, medical comorbidities, visual or other sensory impairments, diminished abilities to perform activities of daily living, depression, alcohol use disorder, malnutrition, use of home opioids or benzodiazepines, having an indwelling Foley catheter, use of physical restraints, or polypharmacy.
Remember, delirium is a set of symptoms. You must go looking for the underlying causes and treat those.
It bears repeating that the manifestation of delirium is a result of an underlying insult. However, there are hypotheses for the pathophysiology, but they're not fully understood. Here are several. Some include excess dopamine, GABA, and serotonin. It may also be a result of structural insults to the blood-brain barrier, or issues with inflammation or excess cortisol. Once you diagnose delirium, what do you do about it?
We're actually going to call this the management of delirium, because remember, to treat delirium, you have to treat the underlying cause. Management involves strategies to reduce the contributing factors to this syndrome and to maintain patient safety. To reduce some of the risk factors, you can discontinue or reduce the dose of deliriogenic medications. There's a long list of these, so you need to review the patient's full medication list. Treat pain, remove catheters if possible, remove physical restraints if possible, and minimize the effect of sensory impairments. Make sure the patient has their hearing aids or glasses. Also, sometimes you need to just maintain safety by placing a sitter at the bedside and trying to prevent falls. Next, change the environment. This is really where the money lies, but it is often underappreciated. Work with nursing staff to make sure the patient is frequently reoriented. Make the space more familiar. Have family bring in pictures, blankets, or other things from home. Reestablish sleep-wake cycles. Hospital rooms are often kept dim, thinking that more rest and less stimulation is better for patients. Actually, this contributes to sensory deprivation. It is helpful to have natural light during the day and keep the room dim or dark only at night. During the day, provide some stimulation, music, interaction with caregivers, etc. Melatonin has been shown to be effective in preventing delirium, so you can start this in higher risk patients at 7 or 8 p.m.
Even though non-pharmacological approaches have the most evidence, sometimes antipsychotics can be used to maintain safety. The rationale for the use of antipsychotics is that this class of meds is based on dopamine blockade. Delirium sometimes presents with hallucinations and delusions, which can cause anxiety and fear. These symptoms have been correlated with dopamine excess. The antipsychotics should be used at low doses and for brief periods of time. Risk and benefits should be weighed with the patient and their loved ones. These are some of my go-to regimens. It bears noting that none of these regimens are standing. All are as needed. This allows you to see if you're actively treating the underlying insult. Remember, patients with Parkinson's disease or Lewy body dementia have a paradoxical response to antipsychotics with significant D2 blockade. So consider Seroquel as your first line, or curbside geriatric psychiatry. Remember to to always get an EKG prior to starting and after starting these drugs, and monitor electrolytes, particularly potassium. Avoid benzodiazepines because they can make delirium worse.
It's 5:45 and our patient Ms. Green is calmer, but now it's time to write your note. How do you know it was delirium? Describe your thought process and the data that led you to this. What's on your differential for the cause of delirium? And what are you doing to treat that underlying cause? What labs do you need to further work up causes? And remember, it is often multifactorial. Don't stop when you find one potential cause. And what are you doing to reduce the contributing factors, like catheters, deliriogenic meds, etc.? And how are you changing the environment to reduce risk and maintain safety?
Here are some take-home points. Delirium is a disturbance in attention and awareness that develops over hours to days, is a change from baseline, and it fluctuates in its severity.
Delirium is a manifestation of an underlying process. Go looking for underlying causes and treat them.
Management of delirium is largely through environmental interventions. Use antipsychotic meds only when absolutely necessary for patient and staff safety. Management of delirium is largely through environmental interventions. Use antipsychotic meds only when absolutely necessary for patients and staff safety.
And the choice of an antipsychotic is based on the patient's age and presence of comorbidities, like dementia, TBI, Parkinson's, or HIV.